In this section, we will go over the answers to the in-class worksheet for bone tissue and bone structure. So the first part is called Margaret's broken hip. Margaret Donovan, a 72-year-old female, was brought to the emergency room by her son-in-law after falling in her bathtub. She was previously in good health, despite leading a relatively sedentary lifestyle and having a 30-pack-a-year history of cigarette smoking. She fell upon entering the bathtub when her right leg slipped out from under her. She landed on her right hip. There was no trauma to the head, nor did she complain of right or left wrist pain. However, she reports severe pain in the right hip and upper thigh and was unable to get up after her fall. After an injection of pain medication, she was taken to the radiology department to get an x-ray of her right leg and hip. The x-ray revealed an intertrochanteric fracture of the right hip and osteoporotic changes in the femur, tibia, and fibula. Question 1. Look ahead in your textbook to Chapter 8 and find a picture of a femur. Can you determine the most likely site of the break? So I'm going to pull up a picture here of the femur, and so you are going to need to know some of these structures when we do get to Chapter 8. So the head of the femur, there are two projections near the head called trochanters. There's a greater trochanter and a lesser trochanter. Then you're going to have a shaft. Then down at the other end where your knee joint is, you have a lateral condyle and a medial condyle. So if we look at our description again of this case study, remember that it said it was an intertrochanteric fracture. So we see two structures called trochanters, and the word inter means between. So this is saying it was between the trochanters. So the fracture should have looked something like this, right? So an intertrochanteric fracture happens between the greater trochanter and the lesser trochanter. Part 2, the femur is an example of a long bone. What are the three main areas of a long bone? Where would you find compact bone, and where would you find spongy bone? So here's another picture of a femur. Remember, we have three parts, starting with the diaphysis, which is the extended shaft in the middle of a long bone. Then you have an epiphysis on each end. So notice how they're labeled. This reviews back to Chapter 1 in your directional terminology. The proximal epiphysis is going to be closest to the attachment site of the leg to the hip, and the distal epiphysis will be the farthest away. So this will be down where the knee joint is. So together, the epiphyses are the expanded areas at the ends, and then the metaphysis is the narrow region between the diaphysis and the epiphysis. So since we have two ends, we also have two metaphyses. So there's one at the proximal end and one at the distal end. Where would you find compact bone in a long bone? Compact bone is going to be in a thin layer around the outside of the entire bone, also called the cortex of the bone. And where would you find spongy bone? You would find spongy bone inside the medullary cavity and also in abundance in the epiphyses, again, which are the ends of the bone. Number 3, explain how the arrangement of spongy and compact bone allow the femur to withstand stresses from many directions. So if we look at compact bone first, remember it's composed of parallel osteons, which provide strength along the long axis of a bone, which is shown by the red arrow here. So think of these little osteons inside as like pillars or columns, and so they help support the bone and provide strength along the axis of the bone the same way that columns and pillars work to support buildings and roofs. Furthermore, the collagen fibers are arranged in spirals inside the osteons, and this also provides some resistance to lateral stresses, which would be stresses that are perpendicular to the long axis of the bone. And then if we look at spongy bone has trabeculae, or these little struts inside that arrange themselves along stress lines, and this allows the bone to resist forces from multiple directions. And so it works kind of like the same way cross bracing works in some bridges. You used to see them in older bridges, but they would help add additional support from multiple directions. And then here is an image of the proximal side of a femur. And in this image, the different stress lines are shown in red and purple. So the part of the spongy bone, the part of the bone that's made of spongy bone helps to withstand these stresses coming from different angles and different directions. And then when they're funneled into the diaphysis, that's when the compact bone takes over, because then at that point it's pretty much just an up and down force. Number 4, why was Margaret's femur more likely to break than a normal femur? Explain the cause for Margaret's loss of bone mass by discussing her risk factors and how they affect the bone remodeling process. All right, so first, why was her femur more likely to break? Well, they mentioned in the description that Margaret's femur showed osteoporotic changes, so that's changes characteristic of osteoporosis. And remember, osteoporosis means there has been enough bone loss to affect normal function. And that means the normal function of a bone is to provide support and hold up your weight. And because her bone has the osteoporosis, her femur was more likely to break than a normal femur. So if we look at Margaret's risk factors, the first strike against her is she's an elderly menopausal woman. So after menopause, women don't produce estrogen anymore. And then also remember, bone deterioration starts at age 30 and continues throughout your life. So the fact that she's an elderly woman and the fact that she doesn't have any estrogen means that her osteoblasts are not as active as they used to be. So the osteoclast activity is greater than the osteoblast activity, and this is going to result in decreased bone density. Another risk factor is her sedentary lifestyle. A lack of weight-bearing exercise will also cause osteoclast activity to outpace osteoblast activity. The body is only going to maintain the strength of bones being actively used. So if the osteocytes sense reduced stresses on a bone, they will actually speed up the breakdown of that bone. It's like, why keep it around if we don't need it? And her third risk factor wasn't discussed in the lecture, but it's a good time to point it out here, is that she was a cigarette smoker. So nicotine and other toxins in cigarettes can actually slow down osteoblasts, if not outright kill them. Nicotine also interferes with the hormones that are necessary for bone health. So nicotine interferes with both estrogen and calcitonin. And smoking can trigger the production of cortisol, which is a stress hormone. It's a glucocorticoid that also reduces bone mass. So cigarette smoking also results in decreased bone density. Question 5 says, the doctor suggests that Margaret avoids long periods of bed rest and begin weight-bearing activities as soon as possible. Why? So bed rest, which is the absence of any weight-bearing exercise because you're not even supporting your own body weight by standing up, triggers the body to increase the osteoclast activity over the osteoblast activity. So that means you're going to have more bone being resorbed and broken down than built back up. So if Margaret stays in the bed during her recovery, she will increase her chances of having another fracture before maybe even she's recovered from this one. Weight-bearing activities, exercises that involve your bones bearing either your weight or additional weights, signal the body to increase bone mass by stimulating osteoblast activity. So in this little picture over here, you see the exercise will increase your bone mass, and we're talking about the femur in this particular case study. No exercise will result in bone loss. So Margaret already has reduced bone mass because of osteoporosis, so she has to do everything possible to have her body try to increase the bone mass, like weight-bearing activities and not staying in the bed. Number 6, describe the changes that a broken bone undergoes as it is healing. So the first stage is that blood vessels break. This is going to cause the death of osteocytes in the area because they no longer get nutrients and oxygen. A fracture hematoma, which is a type of blood clot, forms to stop the bleeding, and there's an area of dead bone around the break from those dead osteocytes. Cells in the membranes, which are the endosteum and periosteum, divide to make osteoblasts and chondroblasts. These cells use bones and cartilage to make a linkage between the broken ends of the bone. There will be both an external callus on the outside and an internal callus on the inside. These will stabilize the break and form a bridge between the two broken ends. Then osteoblasts are going to replace that cartilage with bone. Any dead bone is going to be resorbed and replaced. It'll be resorbed by osteoclasts and replaced with osteoblasts. And at this point, the fracture site is now completely filled in with spongy bone, and this is also the stage where you typically have your cast removed. And the bone's going to continue to be remodeled, and then compact bone will be added to the cortical or outside region. And then over time and with continued remodeling, the calluses are going to eventually recede and disappear. Number 7, Margaret's doctor has told her to start taking oral calcium supplementation. What is required in order for Margaret's digestive system to absorb the calcium into her body? Okay, now I'm going to save the second part for another slide. So in order to absorb the calcium in the digestive tract, the body requires calcitriol, which is a hormone produced by the kidneys. So calcitriol is the signal to your intestinal cells to tell them to absorb calcium and phosphorus from the food and drink that you consume. Calcitriol is made from cholecalciferol, which is another name for vitamin D. So adequate levels of vitamin D are necessary to make calcitriol, and calcitriol is necessary to absorb calcium. So picture's worth 1,000 words. So you get vitamin D either by being in the sunlight. So being in the sunlight causes a reaction in your skin, which converts a chemical to vitamin D. You can also take vitamin D in through your diet, so eating fish, meat, or taking supplements. These are all ways to get additional vitamin D. And then the liver converts the vitamin D into a compound that the kidney converts into calcitriol. And calcitriol is necessary to absorb calcium and phosphorus in the digestive system. So the second part of the question said, describe the role of blood calcium homeostasis and how the homeostatic mechanisms to control blood calcium can affect the bones. So the normal homeostatic blood calcium levels are 8.5 to 11 milligrams per deciliter. So if calcium levels drop below 8.5 milligrams per deciliter, the parathyroid gland is going to release parathyroid hormone. And parathyroid hormone will cause the following events to happen. There will be an increase in osteoclast activity, moving the calcium from the bone to the blood. So this is going to lower bone density. You'll also get an increased kidney secretion of calcitriol, which will signal increased calcium absorption in the intestines from your food and drink. And then you'll also get increased kidney reabsorption of calcium to keep the calcium in the body, meaning the kidney is releasing less calcium in the urine. So all of these things will work together to rise calcium levels back to normal. On the other side of the coin, if calcium levels rise above 11 milligrams per deciliter, you have your thyroid gland releasing calcitonin. Calcitonin will cause the following: decreased osteoclast activity. So less calcium is going to be removed from the bone. Your osteoblasts will still be working as normal, so they may even be depositing excess calcium into the bone. So your bones will become more dense with decreased osteoclast activity. You also have decreased kidney secretion of calcitriol, and the decreased levels of calcitriol lead to decreased calcium absorption in the intestines, so you're getting less calcium from your food and drink. And increased kidney excretion of calcium, and this helps to remove the calcium from the blood and put it into the urine, so now you have more calcium leaving your body through the urine. So all of these actions together will let the calcium levels come back down to what they should be. Number 8, Margaret's doctor also puts Margaret on oral estrogen therapy. Why? Estrogen stimulates osteoblast activity, and it can also inhibit osteoclast activity. So Margaret's doctor is trying another strategy to increase the osteoblast activity with relation to the osteoclast activity in an attempt to reverse her bone loss. Remember, if osteoblast activity outweighs osteoclast activity, you're going to add to the bone and make it thicker and stronger. And this is also to remind you that estrogen and testosterone, which is a type of androgen, they both help to stimulate osteoblasts, which is shown by the black arrow going down here to the osteoblasts. And they also both help to inhibit osteoclasts, which is shown by the red line signal going down here to the osteoclast. So sex hormones increase osteoblast activity and decrease osteoclast activity. Part 2 are some bone growth and hormone questions. Number 1, a race between two runners is often used as an analogy to describe the mechanism of endochondral ossification. Review endochondral ossification. So we're going to do that first. So let's review the process. So steps in endochondral ossification include, so we start with a hyaline cartilage model. The chondrocytes enlarge, and this causes their lacunae to expand. The matrix between the lacunae is reduced to very thin struts, and these start to calcify. The chondrocytes that are isolated now die and disintegrate, leaving cavities behind. Blood vessels then enter the perichondrium, causing cells to differentiate into osteoblasts. The osteoblasts are going to make a thin bone collar around the diaphysis, and the perichondrium is now a periosteum. Blood vessels will then enter the heart of the diaphysis, causing fibroblasts to differentiate into osteoblasts. They will start building spongy bone in the diaphysis, and this creates the primary ossification center. Osteoclasts are now going to appear, and they will start eroding the spongy bone to form the medullary cavity in the middle of the diaphysis. Now with stage 5, we move into the epiphyses. So blood vessels will now invade each epiphysis and activate osteoblasts. The osteoblasts will start making spongy bone in these areas, and these are called the secondary ossification centers. The epiphyses become filled with bone. There's a little bit of articular cartilage that is pushed to the top and will play a role in the joint. And then you have cartilage in the epiphyseal, between the epiphysis and the metaphysis. It's called the epiphyseal cartilage. And as long as that keeps growing, the bone is going to continue to increase in length. At puberty, sex hormones stimulate the osteoblasts to work faster than the chondrocytes that are adding new cartilage. So the epiphyseal cartilage is eventually completely turned to bone, and that creates the epiphyseal line, and at that point the bone will never increase in length. So let's look at the second part of the question. In endochondral ossification, who are the two runners? Did each runner begin the race at the same time? Who is in the lead at the beginning? How does the race end? So the race is between the osteoblasts making bone and the chondrocytes making cartilage. So if we look at the beginning of the race, right, we have chondrocytes in the lead. So this is our little race line, right? This is all taking place at the epiphyseal plate. And so the chondrocytes are the little blue guys, the osteoblasts are the pink guys. So the chondrocytes got a head start because they were making cartilage way before we ever started making bone. Remember, we started with the cartilage model, so we started with hyaline cartilage already in place. So the chondrocytes have been making cartilage since way before any osteoblasts showed up. So the chondrocytes are in the lead of the, quote, race at the beginning. Then, during your entire childhood, the osteoblasts and chondrocytes run at the same speed. And what that means is that as the osteoblasts, shown in pink, go over this cartilage, they are turning it to bone, but the chondrocytes are running at the same speed in front of them, making more cartilage. So the osteocytes are turning this older cartilage into bone, but the chondrocytes are making new cartilage at the same pace. So they're staying the same distance apart from each other. So as osteoblasts make the new bone, chondrocytes are making new cartilage. And as long as this process happens, the bone can increase in length. So the chondrocytes just keep getting out ahead, and the osteoblasts keep following behind at a set length. But at puberty, the osteoblasts are boosted by the sex hormones and they run faster. So what that means is that when puberty hits, the osteoblasts, shown in pink, are going to speed up. They're going to overtake the chondrocytes, and they're going to turn all of the cartilage to bone till we have no cartilage left at the epiphyseal plate. And then once all of that epiphyseal cartilage is gone, the bone can no longer increase in length, Because the osteoblasts in this case have to have an area of cartilage that they're converting into bone. So now the bone is at its final adult length. Number 2, what roles do osteoclasts and osteocytes play in endochondral ossification? Well, if you remember, we mentioned the osteoclasts already. They erode the spongy bone in the center of the diaphysis to form the medullary cavity. And then we've talked about this earlier in chapter 6. Osteocytes are osteoblasts that become surrounded and trapped by bone matrix that they were making. And so once they're trapped and sort of stuck in place, they become an osteocyte and they start monitoring and maintaining the bone matrix in their immediate vicinity. So again, a little picture, osteoblast laying down osteoid. They get stuck in the osteoid as they're building it and adding the minerals, and then they become osteocytes. Number 3, 8-year-old Sandra breaks her leg in a car accident. X-rays indicate that her left femur is fractured at the epiphyseal plate. The bone fracture eventually heals. Years later, Sandra begins to notice that her right leg is slightly longer than her left leg. What might account for the difference in length between Sandra's two legs? So notice that it said the fracture happened at the epiphyseal plate. So that means that more than likely the epiphyseal cartilage there was damaged. So she hasn't reached puberty yet at age 8, so she should still have that epiphyseal cartilage in that location. We talked about this in chapter 4. Cartilage is avascular and heals poorly. So her left leg would have had trouble producing additional cartilage at the epiphyseal plate, and it has to produce more cartilage here in order for the left leg to increase length. And so because it was damaged, it couldn't get the length that it needed, so the uninjured right leg was able to grow into a longer bone. So the second part of the question says, explain Sandra's condition with respect to the race that we described in question 1. So if we take a look at this, so I got her right leg on the right side and her left leg on the left side. So what happened here is during development, right, she broke her bone in that area with the cartilage. So not only damaged the cartilage, but it damaged the chondrocytes that make new cartilage. So whereas in her right leg, those cartilage guys were able to keep running and get way ahead of the osteoclasts, in her damaged leg, the osteoblasts, the osteoblasts were able to catch up quicker and overcome the cartilage and replace it all with bone faster than what happened in the right leg. So she ends up with a shorter left leg and a longer right leg because the right leg's cartilage wasn't able to keep extending as normal. Number 4, 20-year-old Sandra begins to worry about her lopsided legs. She wonders if her right leg will continue to grow longer than her left. Sandra consults a doctor who takes an x-ray of each of her femurs. After the x-ray, the doctor informs Sandra that she has reached full height. She should expect no further difference in length between the two legs. How did the doctor use the x-rays? To determine that Sandra had reached full height. So an x-ray would reveal the presence of an epiphyseal line, and that's shown over here in the right picture. So you see the epiphyseal line here versus where you see an opening in the middle of the epiphysis of a bone. So if you see the epiphyseal line, that means that the epiphyseal cartilage is gone. It has been completely replaced by bone. And also, once you see the epiphyseal line, it means no additional bone length could occur because there's no cartilage left. Remember, long bones can only get longer as long as there is some cartilage left at the epiphyseal plate. So in this case, because the doctor saw the epiphyseal lines, he could conclude that Sandra was as tall as she was ever going to be, and she was not going to get any more height from either leg. Number 5, 6-year-old Jose inherited a disorder that increases the activity of cells in his pituitary gland. Therefore, Jose experiences an overproduction of growth hormone before puberty. What effect would you predict this will have on his height? Explain. So overproduction of growth hormone before puberty means that there is an increase in activity and growth of all cells, and this includes both the osteoblasts and the chondrocytes that are still in the epiphyseal cartilage. So he hasn't hit puberty, so he still has epiphyseal cartilage. So because he's got the cartilage that can keep growing and the osteocytes that will follow behind them, his bones will get very long and he will get very tall, and he may end up even having gigantism, which is caused by too much growth hormone before puberty. Number 6, Russell enters puberty about 5 years later than the average age. What effect would you predict this would have on his height? Explain. So I hope you thought about this before coming to look at the answers, but let's see what the answers are. So remember that at puberty, the sex hormones cause osteoblasts to work faster. When they work faster, they eliminate the epiphyseal cartilage, and that stops the increase in bone length. So remember, basically puberty is stopping the increase in bone length. So the more time you have before puberty, the more time you have for your bones to get longer. So that's more time with the chondrocytes working at the same rate as the osteoblasts. So Russell went to puberty 5 years later, right? So he had 5 additional years that his bones could grow in length. So Russell will likely be taller than others his age because his bones had a longer time to grow longer before getting rid of the cartilage. And number 7, explain why adult women are typically shorter than adult men. So again, remember at puberty, the sex hormones cause osteoblasts to work faster, and this is going to eliminate the epiphyseal cartilage. And when the cartilage is gone, the bone no longer increases in length. Also remember that estrogen increases osteoblast activity faster than testosterone does. So in women, the osteoblasts are going to catch up to the chondrocytes faster, which will stop bone growth sooner and result in shorter bones, which means they'll be shorter. They'll be not have as much height. And again, if we look at our little race example, on the left side here, right, women get a faster boost from estrogen, meaning that the little pink osteoblasts can race up ahead and overtake the chondrocytes sooner, but because they overtook them sooner, the bones end up being shorter. Whereas on the right side, testosterone will also boost the osteoblast activity, but not as quickly as estrogen. So it still takes a while for the osteoblasts to catch up to the chondrocytes. And because it took them longer to catch up, the bones are going to be longer. So this explains why adult women are typically shorter than adult men. Genetics does play a role, but on average, women are shorter than men. And that is the end of the Chapter 6 activity.